I am Tamara Lane, and I am a service manager here at the CARS branch of the Milwaukee County Behavioral Health Division. And today we are going to cover Module 8 of the CCS training, Good Clinical Documentation within CCS. So everybody's favorite topic, documentation. So I included this cartoon because I think it illustrates the importance of documentation perfectly. It says, where would we be without the right documentation? Well, guess what? We'd be unemployed. Documentation is really, really important. I know, in speaking from experience, there have been times where I've said or heard, if I just didn't have to do this documentation, I could do my job. I could spend time with consumers. I could do what I love to do. I'm supposed to do all this work, and now I'm supposed to write about it? There's a reason for that. And in fact, there's several reasons about that we're going to get into. So documentation in the medical record supports the service provider in demonstrating the need for service. So a lot of times at the county level, we look at our levels of care and we look at the utilization of our levels of care. Now CCS is going to be a little bit different because CCS is consumer driven and contacts and the amount of time spent with a consumer is very much individualized and driven by the consumer. Now, TCM and CSP, on the other hand, there are very specific requirements around what we would expect to see as far as the number of contacts and the frequency of contacts we would want to see within those levels of care. So when we are doing utilization reviews and we see in a CSP, traditionally, which is one of our more intensive levels of case management, and we see that the utilization of services is once a month, once a week, it's at that point that there's a red flag. And we go, what's going on here? Is it time for us to look at a different level of care? Is there something else that could better serve this consumer? So we may ask to have a team meeting to discuss exactly what's going on. But the documentation in the record is what is tied to billing. So chances are what we're seeing is tied to your documentation. So if we only have billing once a week, your case notes are probably only going to be once a week. So that's what it means by demonstrating the need for service. Tracks the course of treatment and progress as it relates to the IRP. Remember in the previous module when I discussed the golden thread of your documentation, how the screen ties to the assessment, ties to the IRP. Well, your case notes, every single case note that you write needs to tie back to the IRP in some capacity, and it needs to be clearly stated. In part of my oversight of CCS, I have been reviewing case notes. Case notes in CMHC to see what is actually being documented, what is the quality, where are there areas that we can improve upon. And I can tell you that this is one really, really big area that people tend to struggle with. There's a lot of great descriptions in progress notes or in case notes about what's going on during the contact. However, I have no clue how that ties back to the IRP. So you need to be very specific. The case note that you're writing definitely needs to tie back to the IRP and an intervention listed on the IRP. And if you are providing something that's not on the IRP, it needs to get on the IRP. Your documentation serves as a valid receipt for services for payer sources. So insurance companies, T19, Milwaukee County. Your documentation shows us that you're doing what you said you're going to do. And you're doing it well. So try to think of your documentation in that regard. We are paying you, the state is paying you to provide a service for a consumer to help them recover, to help them get better, and we need to see what you're doing. Protects and assists the provider to testify in situations where legal action is being taken. I'm not a big fan of using scare tactics to get you guys to do what you need to do as far as documentation. But how many of you have had your records subpoenaed? Has that ever happened? Yeah, it's happened to me too. And it's not a pleasant process. And I can tell you, my records were subpoenaed for an incident that had nothing to do with me. One of my consumers passed away while they were in the hospital, and my records got subpoenaed because the attorneys and the family wanted to make sure that we were doing what we should have been doing on our end to support that consumer. So that is really something that's important to keep in mind. And I can tell you that my documentation was really solid and that I had no issues. So while I don't want you to solely case note with that perspective in mind, because it's not 100% cover your back, that's not what case noting is about, but you need to keep that in mind because it is important and it can happen because we are working in a business where some really bad things can happen sometimes. And if it's not in the medical record, it didn't happen. Okay, you hear that a lot, but it's so true. You could say, well, no, I did X, Y, and Z. I did, I promise. But if it's not written, you have nothing to back you up. So if you're on the stand and you're testifying to your medical record, if you don't have very specific evidence supporting what you did or demonstrating what you didn't do, that could be an issue. So just keep that in mind. Oh, the other piece, this is really important, and this is going to be great once we get into Avatar. And actually, I'm going to throw a little wrench in things. All documentation is actually going to take place, all case noting, in Provider Connect. So you guys have the pleasure of jumping between two systems for the medical record. But Provider Connect is a really great program, and from my perspective, it's pretty easy to use. So just so you're aware that all the case noting will go into Provider Connect. And the great thing about that is that everyone on the CCS team that is a CCS provider, you will have access to their case notes. So you will be able to see what's going on in all different areas. There are a few exceptions to that, and we'll get into that later on. But it's a great communication tool for other recovery team members. And I just remember working in CSP that it was great that before each contact with a consumer, I would go back if there was a contact with someone else between that time, and I was like, oh, okay, well this happened and this happened. And this is important for me to be aware of because sometimes consumers may tell things to other treatment members that they might not necessarily tell you, and things may happen that you're not aware of. So it's a great way to communicate between recovery team members. Okay, so we just hit on this, and you've probably heard this so many times, but if you didn't write it, it didn't happen. Okay, your records at some point very well may be reviewed by a judge, by an attorney, by the consumer themselves, a guardian, or the state. The state routinely may come in and say, hey, let's take a look at your medical records and let's see what kind of case notes you guys are producing. We want to see where our money is going. So the case notes really need to demonstrate the services that you're providing and how they tie back to that individualized recovery plan. Warning, warning, pay attention to this. So, let's say you write a to-do item in your case note. Like, let's say a medical issue comes up and you say, will schedule an appointment with Dr. So-and-so for this consumer. And then you don't do it. And then something happens. That's a liability. Including negative, biased, or I'm not even going to attempt to say that because I'll probably butcher that, but prejudiced language. So the medical record is fact. You should not be bringing in your opinions. It should be not written in a derogatory manner, in a disrespectful manner. You are not giving your opinion. You are stating the fact. And later on in the presentation, I will review a case note that demonstrates this and what you should not do. Okay, so make sure that your progress notes are, as we just said, factual, objective, and unbiased. They need to be very specific, clear and to the point, and omit details of clients' lives that do not impact their plan of care. So another benefit that I oversee for Milwaukee County is CRS, Community Recovery Services. And right now, that benefit is in our group homes. And oftentimes I see, client was in bed at the start of my shift. Okay, that's great. Unless that is a rare occurrence for the consumer, it doesn't need to be written in the case note. Johnny had on a red shirt today. Does it matter? Maybe. But if it doesn't tie back to the IRP, it doesn't need to be in there. And I think with good clinical documentation, that comes with practice. You know, I think clinicians start out writing a lot of notes and a lot of detail in notes, which is a good thing because in my opinion, it's important to be detailed, it's important to be specific. And I think over time, you start to develop the concept of what you actually need in a progress note, and then your notes scale back a little bit. But keep this in mind. If it's not treatment related and it's not on the IRP, unless it's absolutely important to the course of treatment, it doesn't need to be in the case note. Avoid using medical diagnoses that have not been verified or diagnosing if you are not qualified. Okay, we may have opinions or impressions of what is going on just based off our own clinical training and expertise. However, if you're not qualified to diagnose, you can't. And if it's not a verified diagnosis, you shouldn't be throwing it around in your case notes. Okay, so according to DHS 36, and this is going to be important because there is at least one other service on the array where this is very, very important. So generally, your progress notes, your case notes, we use those terms interchangeably, need to include service facilitation and progress notes, records of referrals to outside sources, descriptions of significant events that are related to the consumer's care plan and contribute to an overall understanding of the consumer's ongoing level and quality of functioning, evidence in the consumer's progress, including response to services, changes in condition, and changes in services provided. Okay? So your case notes need to demonstrate progress. If there's changes, that needs to be clearly documented. If there's consultation within the team or outside of the team, that needs to be clearly documented. Really, when you review a record, and when I'm looking at case notes, I'm really looking to see the story. I want to see the story of what's been happening with that consumer, how treatment is going, where treatment is progressing, what services are in place, how is that working for the consumer. And I should see a natural progression as I'm reading those case notes. Or regression. That could be happening as well, but I should be able to see that. When our QA team looks at progress notes, they should be able to see it. When Jen Alfredson looks at progress notes, she should be able to see it. So there shouldn't be any question about what's going on with someone because it should be clearly documented. And I can tell you, in reviewing the numerous case notes that I have, that's not always the case. And I really have to talk to the teams to figure out what's going on. We don't want to see that. Your record should tell it all. Okay, DHS 36 continued. You also want to include observations of changes in activity level or in physical, cognitive, or emotional status and details to any referrals. So, one day I went to visit a client at their home, and he could barely walk. He was almost crawling across the living room to see me. And, I'm like, oh my gosh, what is happening? You were just fine yesterday. So, of course, my case note is going to reflect, I got to this consumer's home. He was crawling across the floor, said he was in so much pain that he could barely walk. Bad thing to do? Case note that and then don't do anything about it. Right thing to do? Case note it. Call the doctor. Can I take you to the ER? What can I do? This is what I did in response to that. Okay, you can't just make an observation and leave it at that. You really need to let us know, how did you respond to that situation? In reviewing some of our group home case notes for CRS, we came across something that had said, this consumer's foot hurts. And this went on for 2 weeks. Come to find out in a later note, this consumer had an infection in her toe that went on and on and on, and it wasn't addressed until 2 weeks later. That's not okay. There needs to be that next step. And that is where your clinical judgment comes in. Okay? Case note it. It's important. Case conference and consultation notes. So this is a form of supervision. Remember we talked about all the various forms of supervision in a previous model? Well, you and your supervisor can write case notes and bill for that time. So you're going to want to say inter-office conference or case consultation and head the note. And then what did you guys talk about with that particular consumer? What did you determine? That's the same thing when you consult with a mental health professional on the IRP. If they're not present at those recovery team meetings, that's the same kind of note we want to see. Very important. So you write a note as the care coordinator, and then the mental health professional or the substance abuse professional, they write a note. This is what we did. Billable. Okay, so service provider notes need to be in accordance with standard professional documentation practices, so that's why we're going over this. Okay, we're going to let you know what needs to be in a case note. Okay, so Milwaukee County has launched at least 2 recovery benefits in the last 2 years and at least 1 additional service that we traditionally have not offered before, IPS. So with the launch of these recovery benefits, we are watching them more closely. Because what we want to do is we want to pick up on any ongoing issues early so that we can address them through training, through feedback, however we need to do that to make sure that we don't end up with a mess of a program. Okay, so we are going to be reviewing progress notes, reviewing documentation on a regular basis because we want to make sure that the quality is there and that it stays there. And once we get into Avatar, that's going to be really easy for us because we don't need to request your progress notes anymore. We don't need to request your treatment plans, your IRPs. We have access to them, and we can pull them up and see what's going on. And I can guarantee that we're going to randomly be doing that. So once again, I'm not a big fan of scare tactics to get you to do what you need to do, but I want to have a very open conversation with you about what this could look like and what the expectations are. So this is what we expect to see when we're looking at your progress notes or your case notes. The date and time the service occurred. Now this is going to be very easy in Provider Connect because there's actually a slot where you enter that information. The duration of the service, how many units did you provide? So CCS bills in 15-minute increments. So one 15-minute increment is 1 unit. Okay? When you are providing a service, you can include transportation time. There is an exception to that. So let's say you take a consumer to the doctor and you are strictly just driving someone. You're not talking about symptoms. You're not checking in with them with how their IRP is going. You go to the doctor. You sit in the waiting room. The consumer goes in. They come back out. You bill for the entire time, including your transportation time, yet you did not provide a CCS service. Big no-no. Okay? So it all depends on how you approach it and how you case note it. If you're in the car, and I have done some of the best work in the car, and you're having a conversation about the IRP or this particular service or this particular need, you are providing a service. And you can bill for that service, and that includes your transportation time. But if you do go to the doctor and you're waiting in the waiting room, you can't include that time. Okay? The nature of the contact. Is the contact face-to-face? Is it over the phone? Is it in the community? What services were specifically provided? Okay? And this is the part where you really need to tie that back to the IRP. Okay? And we're going to see some examples where that's not very clear, and I can't stress enough. That needs to be clear. What services are you providing? Okay, so documented services justify the recorded duration of the contact. I have an example of that. Okay, remember that that case note that I told you about where the provider billed 7.5 hours of service? I have that case note. And I can tell you that case note does not justify 7.5 hours of service. So your case note needs to justify the time that you're putting down. Okay, so as we had previously discussed, the services being provided are rehabilitative in nature. So you're really working on the skill building with this consumer. You are modeling, you are teaching, you are prompting. You are working on building skills, and you can use those words in your case noting. The services tie back to the IRP. Huge. Progress and changes in condition or service are clear and evident. Okay? It's not rocket science. This is a good reference point for you too. I mean, think about when you have to do your assessment, when you have to meet with the recovery team and do the individualized recovery plan. Probably a good idea to review your case notes to see where you've come with that consumer. What kind of progress have they made so that you have a conversation point. So as we had just talked about, if there's an observation and a change of a physical, mental, emotional health condition, it's addressed. It's not just put in there and then left hanging. It needs to be addressed. So if another individual is mentioned in the case note, please make sure that you are very clear about the relationship of that individual to the consumer. So if you just throw in, I talked to Mary today, Mary said X, Y, and Z. Who is Mary? We have no idea. Write your case notes from the perspective that an outside source may read them at some point. So that's why it's important to really include those reference points. What is the role of that person in that consumer's life? Huge, huge, huge. And I know Jennifer Alfredson is a huge stickler about this. At the end of each of your case notes, there should be a plan for what you are going to do from now until the next contact, and then your case note should end. Next contact on this date. I can't tell you how many case notes we look at, they don't have this. And all of a sudden a month goes by, no contact, we have no clue what's going on. Yet it says on the treatment plan or the IRP, this consumer is going to be seen once a week. Very, very important to include that. Okay, so CCS has some very specific requirements right off the bat. You have to go out, you have to do your outreach, you have to have that application and admission agreement signed, you have to have your assessment, your functional screen, your IRP, all done within 30 days. Okay? We should be able to see that. We should be able to see the CCS process occurring throughout the case notes, and it should be specifically documented. Met with consumer for the first time on this date. We signed all this very important paperwork, and you can go ahead and list it. Signed application and admission agreement on this date, boom, right there in the case note. That's a reference point for you, and that's a reference point for us when we're looking at case notes. Because then we can see, all right, admission agreement was signed on this date, so we know that within the next 30 days, everything else needs to be completed. And from that point, we should see, entered mental health aorta functional screen on this date. Consumer was found eligible. Completed assessment on this date. Held recovery team meeting on this date. Completed the IRP on this date. Okay, very, very important. So make sure that your case notes specifically reflect dates that this CCS process is progressing. Okay, so like I said, highlight the completion of important CCS paperwork. Signed the admission agreement, did the assessment on this day, completed the IRP on this day, held the recovery team meeting this day. The more specific you are, the better your reference point. Okay? it may get to a point where you guys are doing care coordination and that's your primary role. You could have anywhere up to 20 consumers that you could flex, depending on their needs. Okay? Your documentation, your medical record is going to be a great reference point for you. So if it's like, when did I sign that? When do I need to get this done by? Take a look at your case notes because it should be specifically listed and documented in your case notes. Okay, non-billable services. I've seen some of this. Filing information in the client's medical record. Okay, can't bill for that. That can be part of your time allocated towards CCS, because remember there's the confusing part about CCS where it's what's billable and what's reimbursable, and anything that goes into operating your CCS program is reimbursable. However, the services you deliver are the only things that are billable. So your programs get higher rates because they factor in all the reimbursable. So if you're filing, that's part of your time allocated towards CCS, and that counts towards your rate, but you're not billing. And there will be a non-billable code in Provider Connect. So there may be the option to go ahead and enter a case note related to these kind of things that won't be billable. Transportation without service provision, we talked about that one. Waiting in the lobby, we talked about that one. Your outreach efforts. So you get a case from us, you go out and you call the consumer, you may have to try to reach them in various ways because maybe they're not initially getting back to you. None of that is billable. However, you should keep a log of your efforts outside of the medical record. And ultimately, when we get into Avatar, like I said, there's going to be that non-billable code option where you could document your outreach efforts, but you're not billing for them. So you can only bill once you have that application and admission agreement signed. Once that's signed, you can bill screening and assessment. Okay? Recreational activities are not billable. So once again, this is all related to what's on the IRP and what the consumer needs. So let's say you're working on trying to reintegrate someone into the community. They have social anxiety. You know, they're afraid to go out in public, and you're working on that goal. It's all in how you case note it. And I've seen this. 5 hours of billing. Went to the museum. We had fun. That's great. That's great, but how does that tie back to the IRP? What are you working on during that time? Are you working on managing the symptoms of anxiety? Because this is a really, really intense situation for someone. Maybe that consumer hasn't been out in the last year. That's important to document. That's an important service to provide. But the way that it's documented, sorry, that's not billable. That's not rehabilitative in nature. But it could be. So it all depends on how you case note. Okay, so we hit on this a little bit in a previous module. And I've seen this a lot. And this may just be the limitation of CMHC and kind of how we originally had our process set up, where we were authorizing screening and assessment on the date that we sent a referral. We've changed that process. So until we get the application and admission agreement back from you guys, we're not entering any authorizations for screening and assessment into the system. However, so screening and assessment is authorized. And what I've seen in case notes is that services are actually being provided and billed under screening and assessment. I have to make it really, really clear that unless an abbreviated assessment is in place and an IRP, a mini IRP, has been sent to us indicating that certain services need to be provided, services should not be provided until that IRP is completed and the authorizations are in the system. Okay? That's important because I've been seeing a lot of things that are being billed under inappropriate service codes. So just make sure if there's an immediate need, that's fine. Then you need to do an abbreviated assessment of that domain and send us an IRP requesting whatever services you need so that the authorizations can get in the system and you do what you need to do. Okay? Going to a client's home and the client is not there, that is not billable. Okay? Calling the client and leaving a message. I've seen this a lot. Left client a message. It all depends on how you case note it. Okay? What did you say in your message? Hey, give me a call back. Not billable. But if you said, hey, I'm just calling to confirm our appointment on, July 31st. Okay? So you would say, called client to confirm appointment. Okay? That's billable. But if you don't have direct contact with the client and you document it that way, you can't bill for it. All right, on to the case note samples. These are actual case notes, CCS case notes. All right, so 7/5/15 at 1:30 p.m., 10 units. The care coordinator, Jen Jordan, and supervisor care coordinator, Jessica Morton, names have been changed, met with client at the clinic to review the CCS program with client. Client or care coordinator provided client with information regarding the CCS program, service array, and expressed interest. Client was made aware he would need to transfer to a CCS therapist, which he was agreeable to. During the initial visit, we completed the CCS application and signed the service agreement. We reviewed and signed agency-specific paperwork such as authorizations, no contact plan, identity verification form, HIPAA, rights and grievances, and weather-related safety information. Care coordinator collected information for the mental health aorta functional screen to determine eligibility. Care coordinator notes that client was pleasant and cooperative throughout the process. Electronic signature. Awesome. Really, really good progress note. Okay? So what do we have here? I mean, we have the date, we have the time, we have the units. It was a really ambitious contact, but it seems like they got a lot done. You don't necessarily need to complete this whole process during one visit. It just very much depends on your consumer and what they can tolerate. But I love the detail in this one. We signed the admission agreement on this date. We signed all this paperwork. And then we collected the information for the mental health aorta functional screen. But with every great case note, there's always room for improvement. Okay, so we just talked about what made it great, duration, services provided, the documented services justify the required duration. Let's see, so this is an intake note. The level of detail is perfect. Not all expected case note components will apply during an intake. So what could have made this note better? I think they said that it was, now that I'm reading it, it said that the contact took place in the consumer's home. That's fine. What would have made it better? Oh, my favorite thing. The plan and the next contact date. But otherwise, a really, really fantastic note. A lot of great detail in it. It's going to serve as an excellent reference point for that care coordinator. So that's an excellent example of an intake note. All right. Here's my 7.5-hour note. Okay. So I actually pulled the goal from the IRP because I wanted to see exactly what they were working on. So the goal on the IRP states, MJ will meet with the certified peer specialist who will support MJ's goals and encourage socialization. So here's the note. 7, 6, 15, and 9 a.m., 30 units, 7.5 hours. Certified peer specialist accompanied MJ to art therapy at St. Luke's. Consumer disappointed to find out he had had the wrong day. Consumer takes a lot of pride in his artwork and has some of it hung up in the waiting room. We then went to Omega for breakfast. We went to Walmart for a few things, then went back to his home. We talked about the usual things. One thing was his frustration with his family not accepting him. He had a smoker move in below him, which made him very angry because they told him they wouldn't do that. I allowed him to vent and also pointed out that one can't change people unless people want to change. Also, that he might have to accept the relationship as it is. I spent over an hour trying to negotiate a good price from AT&T for a cable computer and wireless. CPS was unable to get a better price. CPS sent AT&T to payee because they quoted her the wrong price, and CPS could not authorize the higher price. Okay. Whew. Right? Okay, there's definitely some good stuff going on. Okay, we can see that. The heart of CCS is there, supporting the consumer, trying to do some advocating, maybe working on socialization, even though it's not really clearly stated. The whole AT&T thing, that's not really the role of this particular peer specialist because it's not listed on the IRP. And calling AT&T to negotiate a good price, the way it's documented, is not rehabilitative in nature. Okay? The peer support specialist was doing this for the consumer. Now, if the peer support specialist would have demonstrated how to advocate for yourself by calling AT&T and trying to negotiate a better rate, that might work. And then it also would have to be listed on the IRP as an intervention of the peer support specialist. Peer support specialist will demonstrate methods for advocacy to build the consumer's ability to advocate, to get their needs met, however you want to state that, but it didn't say that. On the IRP, the peer support specialist's role was to work on socialization, not calling AT&T. I don't know how going to Walmart ties back to socialization. I guess from my perspective, working on socialization would be like, what skills are you working on? What sorts of supports are you trying to build for this individual in the community? Are you taking them to tour Grand Avenue Club? Are you talking about possible other resources that are out there? To me, you're just taking them out to breakfast and driving them around. And that's not to say that services weren't provided. They very well could have been, and they could have been beautiful and tied back to the IRP. However, the way that it's written doesn't tell us a whole lot, and it certainly doesn't justify 7.5 hours of billing. Okay, so we talk about, there appears to be a lot of socializing going on during this contact. However, the role of the peer support specialist isn't necessarily to just socialize. It needs to be worded and documented in a way that you're trying to build skills, you're trying to model social skills, you're exploring resources that could be helpful to build skills. And then there's a lot of, I took the client here, I took the client here, I took the client here, without really indicating what services are being provided. And there was some conversation about how we talked about the usual, and we talked about how the consumer was struggling with dealing with his family, and there was some really good feedback provided. All great stuff, but you're not just driving someone around, okay? And then we talked about the AT&T bill and how that service really needed to be rehabilitative in nature, at least documented that way, and provided that way. And hopefully it was provided that way, but it doesn't sound like it. And it needs to tie back to your specific role on the IRP. Okay? Oh, so areas in need of improvement to make this note compliant. What services were specifically being provided and how did they tie back to the IRP? So if you're working on socialization, you're working on building social skills, you're modeling behavior, you're teaching different ways to interact that are appropriate. You're exploring external resources that can help support that consumer in socializing. Services are rehabilitative in nature. The big one, documented services justify the recorded duration of the contact. I'm sorry, but 7.5 hours of service is a lot of service. Okay? And I have a lot of red flags come up with that. So, I think that's a matter of supervision too. If you're regularly seeing those kind of numbers, you really need to be checking in with that provider and making sure that they understand what their boundaries are and making sure that everything they're doing is tying back to that IRP. Maybe you have a provider who's just being nice, has a hard time saying no, and maybe getting taken advantage of. You really need to take a look at the services being provided and ask, is there a clinical justification for what's going on? And really, the review of those case notes as far as quality and the appropriateness for billing, that's the job of the service manager. Okay, so your CCS service managers at your agency should have an internal process of regularly reviewing documentation and billing to make sure that it's accurate. Okay, and then it didn't say anything about a plan or the next contact. So we're kind of seeing a theme with that, right? Not really in a whole lot of notes. So make sure that your notes have that in there. Okay, this is not a CCS note, okay, because I can't really see our service providers writing this. It might happen, but I had to actually pull this from somewhere else. So don't get too scared. It's not a real life note, at least in Milwaukee County, that I know of. Okay, 7/7/15, 11 a.m., 4 units. Home visit with Miss Jones. She looked awful. Clothes dirty, hair messed up. She stunk. The apartment smelled like pee. As usual, she complained of not feeling good. Told her to go see her doctor. Will call her care coordinator to find out if she knows anything about why Mrs. Roberts stinks. Okay. Doesn't take a rocket scientist to figure out that this is a horrible note. And this has liability written all over it. It's unprofessional, it's biased, and it's very disrespectful. Okay, this is never okay. So what's in here? Okay, there's some observations. There's some opinions. Opinions are not good. It needs to be based on fact. How about, as usual, She complained of not feeling good. One of those things. Hey, I observed this, but I did nothing about it. And I'll check in with the care coordinator, but clearly this is something that's been going on for a long time, so maybe it needs some further explanation or exploration. Okay, don't ever case note like that, please. I see that, I will personally come to your agency and give you a stern talking to. Okay, so what would need to happen to bring this case note into compliance? We don't really know what services were being provided. Not really sure that the documented services justified the duration of the contact because there really weren't many services recorded. The services, not really sure if they tied back to the IRP or not. It wasn't specifically stated. So progresses and changes in condition were clear and evident. I mean, there was a mention of a change in a condition, but it sounds like this has been going on for some time and it hasn't been addressed. That's an issue. And of course, there was no plan. There was no next contact date. So, okay. We're going to end on a positive note. All right, case note sample number 4. The IRP goal. Jack wants someone to assist him in taking his medications and understanding what his medications are for, as well as identifying the side effects of his medication. So, the issue I have with this, read that goal. Is that really a goal? Sounds like a need to me. And maybe the barrier is that Jack doesn't know much about his medications. So a goal in this situation would be, in the next 30 days, Jack will be able to verbalize the name of 2 of his medications and what they're for. That's a goal. This is a need. This is what Jack wants. Okay, this is a barrier. So remember, I said I'm seeing a lot of goals that are actually needs or interventions. This is not a goal. Okay, make note of that. However, the note is good. 7/14/15 at 8:30 a.m., 5 units. I coordinated with Recovery Inc. to set up the delivery of Jack's medications. Jack was in a good mood, and I watched Jack fill his medication strips for the next week. Jack had mentioned that he would like to keep his medication fill date on Wednesdays in the AM. I did not see a problem with this, and I told him this would work well, but I had to make sure it was all right with Recovery Inc. Jack took his AM medication in front of me, and Jack reported that he had missed a dose of medication over the weekend due to forgetting, and that he felt his symptoms gradually returning. I encouraged Jack to contact his care coordinator if the symptoms got any worse, and he felt he needed any kind of intervention. Jack stated that he felt that now that he was back on track with his medication and that he would be fine. Plan. Right? Jack and I will meet again on June 24th, 2015, so I actually put that date in, so that's why it's ahead of the plan. That was my mistake. To give him medication for the next week. Pretty good. Pretty good note. Okay, there's a couple things that we'll talk about, but what's good about this? So we have the time, we have the units, the date that I actually put in there, but gives you a good idea of what services were being provided and how the consumer was, how are they doing, what were your observations. Noted that the consumer reported symptoms were returning The provider checked in about that, recommended that they follow up with their care coordinator if symptoms get worse. The consumer felt like they'd be okay. So they didn't just throw an observation out there and then do nothing about it. They did a good job. I loved the plan. I loved the next contact. That's really important. So pretty good note overall. Very detailed, which is good. Okay. So let's see. I think we pretty much talked about everything that was good about this note. So let's go back to this note, because I do have a couple concerns. Okay, while this is a really, really good case note, the big concern I have in regard to CCS, do you see that line where it says, let me find it. Jack had mentioned that he would like to keep his medication fill date on Wednesdays in the AM. I did not see a problem with this and told him this would work well, but I had to make sure it was all right with Recovery Inc. Is that really the CCS philosophy? Consumer driven, right? So Jack is saying, hey, I really want to see you on Wednesdays. That works well for me. The provider, I believe this is probably a medication, a med tech, or whatever they're specifically worded at the agency. They don't need to ask for permission from Recovery Inc. They need to inform Recovery Inc. that Jack wants this, but this is not, we don't need to check in with Recovery Inc. and make sure that this change is okay. Okay? The consumer wants it, we need to make it happen. Okay? But it's important that there's communication going back to Recovery Inc. saying, hey, this is what Jack wants, can we make this happen? Okay? I'm trying to think if there was one other thing. No, pretty good. Pretty good. Okay. All right, so I mentioned Provider Connect, which is where case noting is going to take place. So all of the CCS providers on that recovery team, so this excludes, medical providers or your psychiatric providers or anyone who's involved in that consumer's life but not a CCS provider. All the case noting goes in Provider Connect. In Provider Connect, the beauty of it is that your billing is directly attached to your case note. So when you enter your case note, you're entering your units and your time and your service code, and that is going directly to billing. So Provider Connect, like I had said before, it'll give the recovery team the opportunity to see each other's case notes. So remember, I talked about a special consideration. Psychotherapy notes are going to be the exception to the case noting rule. So psychotherapy notes can be really, really detailed and really in-depth and include information that a consumer might not necessarily want the entire recovery team to know. As long as therapy notes meet the requirements outlined under 3618, which we went over earlier in this presentation, that's all those notes need to meet for Provider Connect. Okay? So outside of Provider Connect, a therapist needs to maintain their own medical record, so their own treatment plan, their own detailed case notes, but they still have to come into Provider Connect and write a note that strictly hits the standards outlined in 3618. Okay? If at some point during the recovery process, the care coordinator or anyone else on that team wants to see psychotherapy notes, a separate consent form needs to be signed by the consumer to request those notes. Okay? Some recommendations to help support you in case noting. Carry a notepad with you at all times. What I'm going to stress about that, if you are out in the community and you have a notebook with treatment information or progress information, just make sure that it's not identifiable. No consumer names, no contact info, social security numbers, nothing like that. Okay, so in case something happens, something gets lost, stolen, we don't want to have any of that identifying information out there. Okay, just keep it on the back of your mind. Keep a notepad near your phone. How often do you just get random calls throughout the day, and then before you know it, you're providing services and doing this and doing that? And I think, speaking from experience, you might not necessarily capture everything you're actually doing because you're constantly on the phone, or you're doing this, or you're doing that. So it's just a good habit to have something right there and jot down time. This is what I did, this is what I talked about, this is who I had contact about. Save a half an hour each day to do case noting. So this is probably the big thing about case noting is you don't want to get behind, because then your medical record loses integrity, because you may not be entering the amount of details that you could if you just wrote it while it was fresh in your head. So that's always a good practice. So let's say you're struggling and you're really having a hard time keeping on top of your paperwork, because it happens. We get busy, life happens. That's when you need to approach your supervisor and say, hey, I need some protected time, I need some paperwork time, I really need to get on top of things. If you see someone on the team is really, really good at case noting, ask them what they do. Ask them what helps make them successful. And like we said, secure protected time, so that would be talking to your supervisor. And if need be, turn that phone off for that half hour. Focus on your case notes, because you want them to be accurate and detailed and up to date. And you have to say no. We tend to be really giving people. Okay, it's all right to say no. You need to focus on what you need to focus on. Okay? So just an overview of important points that we hit on around good clinical documentation. So make sure that your documentation is specific and it details the recovery process. It gives us a good picture about what's going on step by step, because it not only serves as a checkpoint for Milwaukee County to make sure that the quality of services and the appropriateness of services is there, but it also serves as a checkpoint and a communication tool for you and your team. So it really, really should demonstrate the recovery process. And we all know that the recovery process waxes and wanes and changes, and we should see that. It should be clear as day what's going on. I don't want to have to guess when I look at your records and see, well, what is going on with this person? Okay? Supports the need for services, so that's that clinical justification piece. Provides protection for you and your agency. And it keeps you focused on what you are working on and why. So like I said, you're going to get busy. You may not remember exactly what I needed to do at this time unless you're keeping like a specific to-do list. I mean, I've got sticky notes all over my computer, but maybe that doesn't work for you. Okay, so your documentation can serve as a reference point for you if you're wondering what you need to do. So the question is there a specific time frame in which you need to enter a note from the time the service occurred. I think right now we are working on revamping our CARS billing policy, and that policy is really going to dictate exactly when progress notes need to be entered. Ideally, you would want to enter them within 24 hours. However, that's not always going to be the case, especially if you're going on vacation or if it's a weekend. So I think what we have in place right now is you want to enter all of your documentation and all your billing by the end of the week so that the billing can generate for the next week. But once that policy comes out, then you'll have more specific information. It's still in the revision and review process. So, but really try to get your documentation in as quick as possible for the reasons that I just talked about. You know, the more time, the more you forget, the less detailed your notes are, and that's really what you don't want to get into.